Can Mycobacterium tuberculosis cause pneumonia? Or is COVID-19 anyway related to pneumonia?
For both of these questions, the answer is a big yes.
If you're not clear about the concepts, there is no problem. ഇന്ന് ഞാൻ പഠിപ്പിക്കാൻ പോകുന്നത് ഇൻഫെക്ഷൻ ഓഫ് ലങ് പാരൻകൈമ എന്ന് വെച്ചാൽ pneumonia. ഞാൻ യൂസ് ചെയ്യുന്നത് 9th edition Robbins, and I have added the necessary updates given in the 10th edition also. Firstly, parenchyma is the functional unit of the lung, which is nothing but the respiratory bronchioles, alveolar duct and alveoli. All the tissue other than this is interstitium. And we all know that we have a lot of blood vessels and a rich supply of lymphatics in the interstitium. To cause an infection, these microorganisms has to reach the parenchyma first. Thankfully, we have a lot of defense mechanisms. If you accidentally aspirate something, you have the cough reflex to bring it out. If those dust particles or food particles or anything are not large enough to elicit a cough reflex, we have the ciliated epithelium until our respiratory bronchioles. These cilia beats in such a fashion that these microparticles are thrown out of the airway. For the final battle of defense, we have the alveolar macrophages, which circulates freely in the airway epithelium and the interstitium. So loss or suppression of any of these defense mechanisms can lead to pneumonia. So before going into the classification, we will try to understand what exactly pneumonia is. Consider a pathogen reaching the alveoli. So naturally, our alveolar macrophages engulf these pathogens and tries to kill it. But in other case, if the pathogen load is more or if the immunity is less, these pathogens starts infecting the parenchyma. This results in an inflammatory reaction in that area. And finally, we have an exudative fluid filling up the alveoli due to capillary leak. This is seen as a whitish area in the X-ray or CT scan. That is what we call as the consolidation. So what I am trying to say is, having a pathogen in the lung parenchyma which is being actively removed by the alveolar macrophages is not pneumonia. It is just a lower respiratory tract infection. But only when the immune system is not able to clear up the pathogen and the host reacting to it, which results in an exudative fluid filling up the alveoli, which is seen as a consolidation in the X-ray, that is pneumonia. So this is the classification of pneumonia syndromes. We have community acquired pneumonia, healthcare associated pneumonia, hospital acquired pneumonia, aspiration pneumonia, chronic pneumonia, necrotizing pneumonia, and pneumonia in immunocompromised host. Lung infection in an individual that is acquired from the normal environment. In it, we have two categories. One is of bacterial origin, the other is of viral origin. In bacterial pneumonia, we have two patterns. Consolidation in the alveoli, which is involving a particular lobe, is called as lobar pneumonia, which is nothing but a typical pneumonia. Consolidation which is very patchy and non-specific, involving all over the lung fields, is called as bronchopneumonia, which is also called as atypical pneumonia. The organisms which causes a typical pneumonia-like pattern are Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, Klebsiella, Pseudomonas and Legionella. Chlamydia and Mycoplasma are involved in atypical pneumonia. Legionella can produce both typical and atypical pattern. And note that viral infection also results in an atypical kind of pattern. So this is a gross picture of atypical bronchopneumonia, and this is a typical lobar pneumonia involving only a single lobe. So the stages of pneumonia includes consolidation, red hepatization, grey hepatization and resolution. In consolidation, the lung is heavy, boggy and red, and it is characterized by vascular engorgement, intraalveolar fluid with few neutrophils, and often the presence of numerous bacteria. So this is what I was explaining earlier. So this is followed by red hepatization, which is characterized by a massive exudation which consists of a lot of neutrophils and red cells and fibrins filling up the alveolar space. Due to the presence of red blood cells in the alveolar space and due to having a liver-like consistency in the gross examination, the term red hepatization was given. Once the red cell starts disintegrating, the red color goes off and gives a grey hepatization. But note that we still have an exudative fluid in the alveolar space. If enough antibiotic treatment is given, we finally go into the stage of resolution, which is nothing but the reabsorption or the enzymatic digestion of the exudative fluid, and the cellular debris are being ingested by the macrophages and all, and this is basically normalizing the alveolar space. So this is a slide of red hepatization, and these are the alveolar walls. So this is the alveolar space which has to be empty, but we can appreciate a lot of red blood cells and lot of inflammatory infiltrates, showing that the exudate has filled up the alveoli. The complication of pneumonia includes abscess formation and emphysema, which is nothing but the infection of the pleural cavity, and bacterial dissemination to other organs.
Now we will come to viral pneumonia. The most common viral agents causing pneumonia are respiratory syncytial virus, influenza virus type A and B, parainfluenza virus, adenovirus, and coronavirus.
Now I will briefly explain how an influenza virus multiplies in an alveolar epithelial cell. Two important glycoproteins present in the envelope are neuraminidase and hemagglutinin. We have surface polysaccharides in the alveolar epithelial cells. The hemagglutinin of the virus binds to the sialic acid residues present in the surface polysaccharides. This helps in the uptake of virus into the alveolar cells by forming an endosomal vesicle. This is basically endocytosis. We have proton pumps in the endosomal vesicle, which is basically derived from the host cell membrane. Pumping the H plus ions into the endosome results in acidification. This highly acidic medium produces a conformational change in the hemagglutinin, which results in the fusion of viral envelope to the host cell membrane, that is the endosomal vesicle. This finally ends up in releasing of the nuclear material into the cytoplasm. So after this, the usual viral multiplication occurs, which is nothing but the synthesis of viral proteins and multiplication of the viral genome. So until now, for the entry of virus, hemagglutinin was required, but for the release of virus, neuraminidase is an essential thing which acts by cleaving the sialic acid residues. So once these alveolar cells, which is nothing but the type 1 and type 2 pneumocytes, are infected by these viruses, sodium channels present in the surface of these pneumocytes are getting inhibited. This results in an electrolyte imbalance, which finally leads to the fluid accumulation in the alveolar space. And these infected pneumocytes die due to the inhibition of host cell messenger RNA translation and due to the activation of capsases. And finally, the recruitment of inflammatory mediators to this place worsens the condition.
To say a few words about human metapneumovirus, they can cause both URTI and LRTI.
So this LRTI can result in bronchiolitis or pneumonia, and it usually affects young children and elderly. So basically where the immune system is less effective. So because of the common symptoms, it is usually mistaken for the influenza virus. So now coming to coronaviruses, this is the update given in the 10th edition book. In Coronaviridae family, we have 7 viruses associated with human infection, of which SARS coronavirus 2 is the virus responsible for the coronavirus disease 19. So SARS-CoV-2 initially causes upper respiratory tract infection, and also the viral load is maximum in the upper respiratory tract in the first week of infection only. Then it reaches the lower respiratory tract. If the host is healthy, the immune system eliminates the virus. The host recovers with mild symptoms or even without symptoms also. But if the patient is a young children, that is less than 5 years, or an elderly, that is greater than 65 years, or in an immunocompromised state, or with any comorbid conditions like hypertension, diabetes, chronic kidney disease and all. In all these conditions, the host immune system is not being able to remove the virus, and this results in viral multiplication in the alveolar cells causing pneumonia. So mild case of COVID-19 is just a respiratory tract infection, but moderate and severe cases of COVID-19 is nothing but pneumonia. Not only coronavirus, but any pathogen causing pneumonia can lead to sepsis, and this sepsis can anytime trigger ARDS, which is nothing but acute respiratory distress syndrome. So now this is an upcoming favorite question for the professors. To which receptor does the coronavirus binds to? The answer is ACE2 receptors present in the airway epithelial cells. And the viral multiplication is almost similar to that of influenza virus, but the coronavirus contains a positive sense RNA and it has a different glycoproteins in the envelope, namely spike protein and membrane protein. And my last point in community acquired pneumonia is that the viral infection can damage the mucosal area apparatus that increases the risk for secondary bacterial infections to occur. Hospital acquired pneumonia is nothing but the infection occurred in the course of hospital stay. The most common organisms involved in hospital acquired pneumonia are Staphylococcus aureus, Streptococcus pneumoniae, Enterobacteriaceae, and Pseudomonas species. Hospitalization of at least 2 days within the recent past, presentation from a nursing home or a long-term care facility, attending a hospital or a hemodialysis clinic, or a recent intravenous antibiotic therapy or a chemotherapy. An individual with any of these history acquiring a lung infection, that is healthcare associated pneumonia. The organisms includes MRSA and Pseudomonas aeruginosa. Aspiration pneumonia occurs due to aspirating the gastric contents either while unconscious or due to repeated vomiting. The resultant pneumonia is partly chemical due to the irritating effects of gastric acid and partly bacterial. Lung abscess is the most common complication. Usually more than one organism is recovered on the culture, and aerobes are more common than anaerobes. So this is a table of organisms which causes pneumonia in an immunocompromised host. So there is nothing much to explain in here. We'll move on to the next thing. Chronic pneumonia. Chronic pneumonia is a localized lesion in an immunocompetent patient. Note that it is not in an immunosuppressed patient. It happens only in immunocompetent patient with or without involving the regional lymph node. The inflammatory reaction is a granuloma formation, which is basically a type 4 hypersensitivity reaction. Consider a Mycobacterium tuberculosis entering a host for the first time. In an immunosuppressive condition, this infection leads to the primary symptomatic TB, where there is no granuloma formation. The mycobacterium multiplies in the lung tissue, which results in an acute presentation. While in case of an immunocompetent patient, the cell-mediated immunity is responsible for the granuloma formation. This seals off the mycobacterium and prevents it from further multiplication. So this condition is the primary asymptomatic TB, or which is popularly known as the latent TB infection. So this granuloma formation for a pathogen in an immunocompetent patient is what we call as the chronic pneumonia. So the Mycobacterium tuberculosis is dealt in chapter 8, which is infectious diseases. You can refer there. Here we will discuss about some fungal organisms responsible for chronic pneumonia. Histoplasma capsulatum is a 3 to 5 micrometer thin-walled yeast forms. There will be central areas of caseous necrosis around which the granulomas are formed. So this produces a large area of consolidation. With spontaneous resolution or with effective treatment, these granulomas undergoes fibrosis and appears as a tree bark. So this is a silver stain, and you can clearly see the thin budding yeast cells. Blastomycetes dermatitis is around 5 to 15 micrometer yeast cell, and it has a thick double contoured cell wall and a visible nuclei, and are usually involved with suppurative granulomas. So this is a H&E staining, and this is the round budding yeast cells which are larger than the surrounding neutrophils, and this is again a silver staining, and you can see the double contoured cell wall. Coccidioides imitis has a thick-walled non-bedding spherules of 20 to 60 micrometer in diameter and often filled with small endospores. Rarely it can progress to skin, bones, adrenals, lymph nodes, spleen or liver, but anywhere it infects, the pathogenesis is granulomatous inflammation. And this is how Coccidioides imitis is seen in an H&E staining.
And this is it. We have completed pneumonia under pathology. But what I am saying is, pneumonia is more related to microbiology and pharmacology and obviously medicine.
For example, the empirical treatment for bacterial pneumonia includes macrolides such as azithromycin or clarithromycin, and use cephalosporins like ceftriaxone. Actually, the stages of pneumonia doesn't have any clinical value. The management is not going to change according to the stages. The only thing is it is being asked in the viva and is an important theory question. Coming to viral pneumonia, what I have explained is actually microbiology part, and the drug of choice for influenza virus is oseltamivir, and the only drug of choice for human metapneumovirus is ribavirin. And yes, until now we don't have any FDA approved drug or vaccines which acts against SARS-CoV-2. And the management part goes on like this. I'll stop here. Thank you so much.